Hello again, everyone. My name is Richard Knight. I want to thank you for joining us for the second annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. Today, I have the pleasure to introduce Dr. Ashte Collins, who is Assistant Professor of Medicine and Director of the Home Dialysis Program at George Washington University, as well as Dr. Michael Aragon, who is the Chief Medical Officer for Outset Medical. They will present on a global need to support an ever-growing home dialysis community, peritoneal dialysis, and home dialysis. We appreciate Drs. Aragon and Collins for taking the time to share their insights on research and home dialysis options and how timely research and innovations can improve patients' quality of life. On a very personal note, if I ever have to go on dialysis again, I will choose a home dialysis option. So I, along with many of my fellow patients out there, should pay particular attention to this session.
Well, thank you very much, and thank you to the AAKP and GW for giving me this opportunity to speak today. As mentioned, my name is Dr. Michael Aragon, and I'm here to lead a discussion regarding home hemodialysis. Before I begin, I'd like to share a disclosure. I am currently the Chief Medical Officer of Outset Medical. I have no other disclosures at this time. Well, before we jump into a discussion of home hemodialysis, I'd like to start with a very brief history of the therapy. One, to better understand the fact that this is not a new therapy when it comes to dialysis, and also to better understand what has happened historically over time with this modality. So as we all know, dialysis was begun in the 1960s in the United States. And once we were able to recognize that this was going to be a valuable chronic therapy for patients with end-stage kidney disease, it was very quickly recognized that this is a modality that should be done at home. In a few years, the first patients went home on home hemodialysis, and it was in the 1970s, just prior to Medicare taking over payment for end-stage renal disease, that 40% of the ESRD population were performing dialysis at home, and in certain areas, that number was as high as 90%. Fast forward to 2018, where HHD as a chronic modality is less than 2%. And then also look at 2019, where secondary to the executive order, part of the AAKH initiative has mandated, and in my opinion, really challenge us to do better, to reach a goal of 80% of incident patients at home and transplant. While the discussion could be that patients in the 1960s and 70s were a much different population than the population of today, I think by looking at the photo here, we also can make the argument that technology today is also significantly different and significantly simpler than it was back in the 1970s, and that our ability to remotely monitor care for patients and the amount of knowledge we have on what is appropriate for the management of end-stage renal disease patients has also significantly advanced. So as we think about the home hemodialysis modality, and one potential cause for its falling out of favor in terms of use could be related to outcomes. If the modality itself is not clinically effective, it would naturally follow that physicians and patients would not pursue that modality. However, that's not the case with home hemodialysis. As we've seen with multiple reports, multiple studies over the years, treatment at home at frequencies of greater than 3 times per week has been associated with not only improved quality of life and reduced dialysis-related symptoms, we've also seen improved technique survival compared to other home modalities, decreased overall infection rate compared to peritoneal dialysis, lower hospitalization rates, improvements in blood pressure, reduction in medications, and we have had several reports of improved survival. However, there have also been some reports of adverse events related to more frequent therapy. And as we have seen through the FHN trial and other trials looking at 6-day-a-week therapy, the increased frequency has also been associated with some negative effects. We have noted that there has been accelerated loss of renal function in patients dialyzing at 6 days per week. There has also been increased vascular access complications and need for interventions, as well as increased infection risk and increased infection-related hospitalizations compared to 3-time-a-week therapy, despite the reduction in cardiovascular-related admissions associated with more frequent therapies. And Dialysis at this frequency has also resulted in a very high burden and, as a result, a higher technique failure than would be desirable, although still lower than other types of home therapy. So given this information with both the positives and negatives, how does that affect the way physicians prescribe and view the therapy and modality itself? There have been multiple surveys over the years asking physicians regarding opinions of dialysis modalities in general. I've highlighted just a few here. The 2010 US Physician Survey simply asked clinicians, both physicians and nurses, several key questions. One, what is their preferred modality? Should the modality be viewed as a bridge to transplant? And two, if transplant is not an option, how would they view and prioritize modalities? Both physicians and nurses gave strong preferences to home modalities in general, but as you can see from the data presented, both also preferred home hemodialysis to peritoneal dialysis if this were treatment for themselves, either as a bridge to transplant or if transplant were no longer an option. As we look internationally, this 2014 survey asked physicians several questions related to home, PD, and in-center hemodialysis. And with that, physicians demonstrated a very strong preference for home hemodialysis as responsible for better outcomes than PD, that increasing dialysis frequency above 3 times a week is clinically beneficial and improves outcomes, and that home hemodialysis provides better quality of life compared to in-center hemodialysis. So with the strong preference and positive clinical outcomes that physicians recognize with home hemodialysis, why might they not be prescribing this as often today? And I think some of that revolves around this nephrology fellow survey in 2012 published by Jeff Burns, which demonstrated that 80% of our graduating nephrology fellows do not feel competent in providing home hemodialysis therapy, and greater than 65 did not feel competent in providing self-care hemodialysis. In stark contrast to that, over 80% felt very competent in in-center hemodialysis. And in my opinion, this is likely a very strong reason why graduating fellows continue to prescribe in-center hemodialysis as they're providing the therapy that they feel most competent in performing. So understanding a little bit about the physician aspect, as well as the physician's view of the modality and possibly their comfort level with prescribing the modality, I think it's also very important to look at patients and care partners and what is important to them when it comes to end-stage renal disease care. So as we look at what's important to both patients and care partners, there have been multiple surveys done to look at what is important to patients as they look at their care for end-stage kidney disease. As I've highlighted in this survey here, patients were given options of over 60 different outcomes related to end-stage kidney disease and asked to rank those in terms of level of importance. Those outcomes were bucketed into 4 different buckets that are listed here, and they are ordered in the order in which patients and care partners gave them a level of importance. As we can see, lifestyle and psychosocial was most important to both patients and care partners, followed by mortality, comorbidities and complications, symptom management, and finally, biochemical parameters. In fact, 9 of the top 10 were related to lifestyle and psychosocial, with management of fatigue being the top rated outcome by patients and care partners, with the other 8 out of the top 10 being related to independence, dialysis-free time, and sleep. Blood pressure management was the only clinical parameter to make it in the top 10. Biochemical parameters that we typically speak to our patients about regarding anemia, phosphorus, and potassium were in the 20 to 30 range, and dialysis adequacy was outside of the top 50. Highlighting here the difference in what patients and care partners find important. As I presented earlier, the data with home hemodialysis regarding quality of life, dialysis-related symptoms, again, you can see where home hemodialysis aligns very well with what patients and care partners deem important. So understanding that level of importance, as well as physicians' views on home hemodialysis, could it possibly be that economics are the reason that home hemodialysis has not grown as we would have expected? So there's been various different economic analyses looking at home hemodialysis, both within the United States, but also internationally. Most of them are variable and very complex to determine when you look at a total cost of care in a system that buckets costs into different inpatient, outpatient, and medication type expenses. But I think one thing that has been consistent is that hospitalizations are a significant cost to Medicare and to the cost of care of end-stage renal disease. And in addition, beyond financial cost is also the cost to the patient, both physically and emotionally, as well as to their care partner, who may also be employed and have other responsibilities, and the cost of their time and effort to care for a patient who has become acutely ill in the hospital. So seeing hospitalization as a cause for increased cost, I think it's important to highlight the association with mistreatments and the effect on hospitalization. In this study, looking at mistreatments, patients in an in-center environment averaged approximately 7.2 mistreatments per year. And with that, the likelihood of being admitted in the following 48 hours after a mistreatment was fourfold higher after mistreatment for patients who had missed a therapy, and twofold higher to have an ICU admission. The study did go further, though, to try to better understand why patients were missing treatments. And as you can see here are the top 4 reasons why patients missed therapy in this trial. And with that, again, you can see how a home hemodialysis therapy could easily address concerns about holidays and personally important events such as birthdays, difficulty with travel related to either snowfall or just general transportation problems, and also difficulty with GI upset where a patient may not feel comfortable coming to an in-center environment while they're having GI-related symptoms. So cost effectiveness of home hemodialysis related to hospitalization seems that the therapy would be very valuable to expand in our current environment. But there are some barriers to home hemodialysis, and they have been identified. As a joint effort between the NKF and KDOKI, there was a conference called to dig deeper into the barriers of home hemodialysis. This work group with multiple supporters, again, bucketed the main barriers to home hemodialysis into 4 different buckets. They're listed here on this slide, and clinical was identified as one of the higher buckets. And with that is not only the misconceptions related to home hemodialysis therapy, but also the need to improve training and the lack of prescribing competence that we see within both physicians and nurses. Operationally, it was noted that there's not sufficient home hemo programs to support the need to expand this therapy. And also there is a difficulty in transitioning patients into a home dialysis environment, particularly the lack of any urgent start home programs to be able to transition those that crash into dialysis to a home modality as opposed to an in-center modality. They did identify that there are significant economic disincentives that may limit physicians and providers from expanding home programs, and that there are significant patient and care partner related barriers that need to be addressed, specifically around burden as well as device complexity. So in line with the barriers identified by the NKF and KDOKI work group, several studies have been done to look at why patients may not maintain on home hemodialysis. I've highlighted here a study by Polly and group published in AJKD in 2018. This looked at 10-year data on home hemodialysis for patients in Canada. At the end of 10 years, 20% of those patients underwent a modality change, with the most common causes of that change listed here. And as you can see, relocation, loss of social support, and inability to cope were some of the top reasons why patients may move away from home hemodialysis, which again highlights the patient and care partner related barriers, as well as the need for operational and clinical efficiency to be able to support these patients, which could have likely led to improved technique survival. Polly and group went one step further to look at what are the associations with technique failure. And other than advancing age and increased frequency beyond 3 days per week, there were no other associations that would cause a patient to be more likely to have a technique failure on home hemodialysis. So with that, the work group did also work on solutions and reconvened in approximately 1 year. This same group reconvened to review solutions to these barriers and found that they're not only practical, but also realistic. Solutions to resolve barriers included streamlining the entire process from getting access to getting started on home therapy. Again, addressing barriers to urgent start home hemodialysis programs. And if I may say, what may be our most effective way of doing this would be allowing self-care and home training to start in the hospital for those patients with crash starts, as opposed to waiting until they get out into the in-center environment to hopefully a dialysis facility that provides home therapy as their only means of getting access and understanding and education to self-care and home modalities. They also highlighted, again, improved education, not only to patients in terms of resolving misconceptions, but also the importance of improved education of our nephrologists and our nurses. From a technology standpoint, the need to expand telehealth and remote monitoring, as well as redesign home hemodialysis machines to not only be easier to use, but also to help relieve burden. And finally, the need to expand clinical knowledge to better understand more effective screening and education, better monitoring of patients and care partners that may be overburdened and how better to address those, and as well as better education and clinical knowledge on how to align reimbursement models to encourage home modalities. And finally, it did highlight the need for extended understanding in terms of what is the optimal frequency for home therapies. So with that, I'd like to quickly summarize and then give my call to action. Home hemodialysis remains critically underutilized, despite being able to demonstrate improved clinical outcomes, a clinician benefit, and significant alignment with what patient and care partners find important and prioritize to their care. And while we have clear evidence that greater than 3 times a week dialysis is beneficial, daily hemodialysis has been associated with increased negative complications, including vascular access interventions, possibly infection-related hospitalizations, and does increase significantly the burden on patients and care partners. And finally, there are barriers to home hemodialysis that can be addressed with new technology, improved education, and more clinical data regarding what is the optimal treatment time and frequency with patients. So with that, we must expand home hemodialysis if we're going to, 1, improve the care of our patients, and 2, achieve the AAKP goals. 2, we must design our care models, education, and reimbursement to incentivize sending patients home to do their therapies and supporting them while they're in the home environment, including considering allowing acute hospitals to begin that self-care and home training process where patients are crashing into facilities as opposed to waiting when they become outpatient in-center dialysis patients. It is critical that we improve home modality training for our nephrologists and nurses. We must continue to improve home dialysis devices and expand telemedicine to further reduce burden, simplify treatment, and allow flexibility. We must place a greater emphasis on what is important to both the patient and the care partners. And provided the complications of daily therapy, we must focus more on extra day therapy beyond 3, but intervals between 3 and 6 days, which could help provide an excellent balance between the clinical benefits of more frequent therapy, but also reduce the burden on patients and care partners and enhance technique survival. So with that, I'd like to thank everybody for the attendance and appreciate the opportunity to speak.
Hello, my name is Ashte Collins, and I'm faculty for George Washington University. I'd like to thank the AAKP for this opportunity, and today we will be talking about peritoneal dialysis and its place on the world stage. We'll start with the benefits of peritoneal dialysis compared to conventional in-center hemodialysis, or ICHD, the current state of PD in the US and around the world, real and perceived barriers to PD penetration, and successful PD program implementation in a low-resource region. Lastly, we'll round out by broadening the concepts applied in that and other PD programs to discuss opportunities for supporting the growth of PD throughout the world. The benefits of PD include, but are not limited to, increased autonomy and eliminating the need to drive to a dialysis center on a regular basis, since it is a home-suitable modality. PD confers fewer dietary restrictions, less hemodynamic instability owing to the slower removal of extracellular fluid, and lower medical staff use that more than compensates for the increased upfront staff utilization for training. PD may be advantageous in developing countries because of its simplicity of therapy, reduced need for trained medical staff, and a minimal requirement for technical support and electricity when considering manual PD. When compared to ICHD, PD is also associated with a longer preservation of residual renal function, which may confer a survival benefit in the first few years of renal replacement therapy. It's associated with lower hospitalization and access intervention rates compared to ICHD, and possibly greater patient satisfaction. The lower cost associated with PD compared to ICHD in the United States is represented in this figure from the 2019 United States Renal Data System Annual Report, with the cost of HD in blue and PD in yellow. Although ESKD costs for all renal replacement modalities have risen slightly over the years, PD remains 15% less expensive than HD in the United States. The most recent epidemiologic data suggests that PD is utilized in about 11% of the world's dialysis population. While the number of patients per million utilizing PD has increased in both developed and developing countries, a 2012 study published in JASN by Jane et al. Showed a relative decline in the proportion of ESKD patients treated with PD in developed countries as of 2009. Also, while the annual global growth of PD slightly outpaces HD, there's substantial variation in PD penetration between different countries, including different regions of the same country. This figure, also from the 2019 USRDS data report, shows that in 2017, 10.2% of all ESKD patients in the US on dialysis were treated with PD. Despite the prevalent PD population in the US increasing 92.5% between 2000 and 2017, the prevalent HD population increased by 84.1% and thus represents a larger proportion of all ESKD patients by treatment modality. Using Asia as an example, this figure demonstrates the wide variation in PD penetration by region, ranging from as high as 73% in Hong Kong to as low as 3% in the similarly developed nation of Japan. It's important to note that dialysis services in Japan are delivered by private providers, which appears to be directly related to its low PD usage. Over time, different countries and regions within countries have experienced substantial fluctuations in PD usage. Thailand, for example, implemented a PD first policy in 2008, reducing the duty on imported PD fluid, resulting in an increase in PD use from less than 10% to 23% in 2012. In the United States, increases in PD utilization tracked with the implementation of the bundled ESKD reimbursement policy in 2011, which incentivizes therapies that use fewer injectable drugs, such as erythropoiesis stimulating agents and vitamin D receptor agonists. This policy change is responsible for much of that 92.5% increase in prevalent PD use I mentioned earlier. The growth and density of community-based dialysis facilities has still outpaced the growth of the population, making it easier for patients to receive in-center hemodialysis. As a result, there remains a relatively low density of PD centers across the United States. Latin America is home to 25% of the world's PD population. As a matter of fact, Mexico and El Salvador have PD usage that outpaces HD usage. There remains a nephrologist shortage in many Latin American countries, with many of the Mexican PD centers actually being run by non-nephrologists. The middle panel shows regions where there's been a relative decrease in the proportion of PD use. Oceania and Europe have had increases in home hemodialysis and kidney transplantation, leading to a proportional decline in PD use. African countries continue to have the lowest access to renal replacement therapy, owing to a lack of availability and prohibitive costs of PD fluid. Contrary to the United States, PD is 72% more expensive than HD in South Africa. These issues, combined with the low density of nephrologists in sub-Saharan Africa, lead to static PD utilization across the continent. Canada has had a sustained increase in HD capacity with a proportional decline in PD use. There are also substantial provincial differences in PD penetration, from as low as 7% in some provinces to 26% in others, since single payer policies and reimbursements are set at the provincial level. There are many factors that impact PD penetration. Legislated healthcare system factors strongly influence PD penetration in regions such as Thailand, Hong Kong, China, the US, and Oceania. On the other hand, industry and facility factors strongly influence PD penetration in African and Latin American countries. These system-related factors say nothing of the individual patient factors that may either facilitate or hinder an individual's recruitment into a PD program. Patients' cognitive function or healthcare literacy notwithstanding, If patients do not receive pre-dialysis education about peritoneal dialysis, they're much less likely to adopt it as a renal replacement therapy modality. Patients should be given network opportunities to educate each other to address fears and cultural differences. Furthermore, patient or caregiver burnout can hamper recruitment and retention in PD programs. Adequate PD training and experience of nephrology healthcare providers, particularly while those providers are themselves in training, is critical to successful PD program implementation on a large scale in any region or country. Modality factors such as limited access to PD fluid, lack of local and national PD registries to track patients, and lack of social support can also hinder recruitment and retention of PD patients. These barriers to PD implementation remain relevant despite unique socioeconomic, demographic, and infrastructural factors among different countries. Guatemala, for example, is a predominantly low to middle income country that's home to 16 million people. It unfortunately experiences a CKD mortality 3 times that of the United States. 40% of Guatemalans are rural indigenous Maya who face significant socioeconomic, geographic, and language barriers in accessing specialty nephrology care that is only available in the urban tertiary centers in and around the capital city. Nephrology care for Guatemalan adult patients with end-stage kidney disease, including dialysis care, is primarily delivered by the National Center for Chronic Renal Disease, which is unfortunately overburdened and underfunded. It has to pay out of pocket for dialysis-related medications, which can cost more than their patients' yearly incomes. If patients do not make it to the capital city for their monthly visit, their supplies may be delayed. The trip takes a day or more and results in decreased wages for that patient. Furthermore, the National Center for Chronic Renal Disease care is only delivered in Spanish. Meanwhile, 25% of Guatemalans are monolingual in whatever their indigenous language is, so they literally cannot comprehend the information presented to them, thus making it harder to perform home-suitable dialysis. Wukukawak, a Maya Health Alliance, provides health services for Mayan patients in rural Guatemala and has since partnered with the National Center for Chronic Renal Disease. They provide patient navigation and primary care coordination services to the indigenous Maya, overcoming the language, literacy, logistical, and financial barriers to PD implementation. They have successfully built sterile dialysis rooms in the homes of Mayan patients. They recruit professional Maya social workers and patient navigators to link these rural communities to the urban referral centers and have supported 25 rural patients on continuous ambulatory PD since 2007. A 24-hour nursing hotline is accessible to all patients to answer questions and concerns. Over this 10-year period, between 2007 and 2017, there's only been one case of iatrogenic peritonitis reported. Wukukawak is an NGO, but imagine what would happen if it truly had the governmental support that that community needs. This Guatemalan model of PD implementation in a rural community exemplifies some of the factors that could improve access to and expertise in peritoneal dialysis. Every country has unique factors that will determine the areas that must be prioritized to improve the availability and effectiveness of PD. Optimizing healthcare organization to implement PD first or PD favored policies, incentivizing reimbursement for PD utilization, and developing training, research, and education networks for PD can all increase its penetration. The COVID-19 pandemic further highlights the importance of establishing systems of remote patient monitoring to augment the retention of patients in any PD program. Such a system would serve as a framework for monitoring patients at home by using digital wireless technology. The hope is that these technologies would improve clinical outcomes through earlier recognition and correction of problems. The technology can also decrease the amount of data that patients must manually record. which would increase their acceptance of the technology. The figure on the right shows three circles. The inner circle of this figure represents examples of individual patient monitoring variables, such as the PD fluid type and volume, ultrafiltration data, vital signs, machine alarms, and video conferencing. Moving outward, data can then be used to drive patient and center-specific clinical care on a longitudinal basis. The outermost circle would be the predicted healthcare-related outcome improvements, such as improved PD adequacy, cost reduction, early problem identification, and decreased patient burden, which can improve burnout measures. Telemedicine has long been a part of PD management. A recent Italian study showed that using Baxter's home choice Cleria with ShareSource permitted adaptive change in prescription, and the night alarms reduced with significant reduction in the need for in-person visits compared to historical controls. In this study, remote patient monitoring was associated with 105 fewer hours spent on clinical care by the nurses and physicians enrolled in the study. This suggests that remote patient monitoring can achieve time and cost savings for both providers and patients by allowing for more personalized therapy regimen and early detection and resolution of technical problems. The figure on the right shows both the Baxter Home Choice Cleria and Omnia PD machines, both of which use ShareSource 2.0 that launched in 2019. To make any PD first or PD favored policy successful, policymakers in any region or country must address 5 important elements systematically: government and reimbursement policy, economic factors, healthcare provider education, modality related factors, and patient related factors. In detail, government policies of any kind must receive budgetary support or else they will simply be ineffective. They should also set benchmarks with detailed funding plans to facilitate patient-centered care, where patients are empowered to make modality choices. Any economic evaluation of a PD program should include country-specific cost data, as well as information on patients' quality of life and employment status. Successful PD programs can radiate from identified centers of excellence, where key subject experts work alongside those centers to form a functional hub and spoke service network, as is done in Australia, where the tertiary care centers serve as the hub and the satellite centers are the spokes. Both patients and healthcare providers should attend unbiased end-stage kidney disease education programs to identify and address anti-PD biases. Local and national PD registries and surveys should be established with their data analyzed on a regular basis and preferably published through national or international conferences and journals so the information can be disseminated. Those fears and cultural differences experienced by patients should be addressed on an individual basis. While web-based and printed materials can be valuable, those networking opportunities can really help the patients educate each other in both the medical and non-medical aspects of PD. In summary, there are many real and perceived benefits of PD compared to in-center HD. Global utilization of PD has increased, albeit with substantial regional and national variation. Industry, patient, facility, and healthcare system factors can all influence recruitment and retention of PD patients in various regions to different degrees. And aligning government policies with the needs of the patients, physicians, nurses, and dialysis centers who are principal to applying ESKD care is needed in order to support the growth of PD throughout the world. Thank you.
Dr. Collins and Dr. Aragon, I want to thank you on behalf of AAKP and the George Washington University School of Medicine for giving us a fine presentation. Me, as well as my fellow patients, really appreciate the choice that home dialysis offers us, and you have given us the very latest in some of the things that are going on in home dialysis.